So someone wanted to know how to deal with the skull-base meningiomas and what the neuro findings are for skull-base neuro meningioma. And really, it's about one thing only: location, location, location. And so when we are dealing with meningiomas involving the skull base, of course, optic nerve and optic nerve sheath, and that can be primary in the sheath alone, and that's going to present with an optic neuropathy, either discedema, pale nerve, or normal nerve. The primary treatment, if it's in the sheath only in the orbit, is radiation therapy. However, if it's coming from inside your head, sphenoid wing meningioma, clinoid, and then going into your orbit, then that normally needs a multidisciplinary approach, including neurosurgery to decompress the component that's intracranial. And if it's intracranial and intraorbital, you need to be aware of that because you might not be able to get a gross total resection. If, however, it's in the sella, then you're going to be just like pituitary adenoma, one eye or both eye vision loss, bitemporal hemianopsia, tract lesions causing homonymous hemianopsis. The radiations and the cortex can be affected because you can have temporal or parietal meningiomas or occipital meningiomas. And even though those are extraaxial lesions, those can produce homonymous hemianopsias from mass effect and from adjacent edema involving the posterior visual pathway. So we can have meningiomas that are involving the anterior visual pathway, optic nerve chiasm tract, or in the posterior pathway, radiations and the occipital cortex, leading to homonymous hemianopsia. If, however, your meningioma is not involving the afferent pathway, but it's involving the efferent pathway, then those are also skull base lesions as well. And so you could be in the orbit again, that's going to be ophthalmoplegia, proptosis, optic neuropathy. It could also be efferent in the cavernous sinus. So in your cavernous sinus, that's cranial nerves 3, 4, 5, subdivision 1 and 2, and 6, cavernous sinus meningiomas. You can have meningiomas in the cerebellopontine angle. That's going to cause 5, 6, 7, 8, or any combination. You can be in this bone right here, which is like the slope, which is called the clivus. And that clivus meningioma can cause 6 nerve palsy. And you can be in the foramen magnum, which is the big hole connecting your spine and your brainstem. And foramen magnum lesions can cause downbeat nystagmus and lower cranial neuropathies. And so you need to know that both the afferent system and the efferent system are affected by meningiomas. And the main driver is location, because almost always these meningiomas are low grade, WHO grade 1, and the treatment is surgery. So you got to know where it is and correlate it with what it's causing, both on the afferent and efferent side. You need neurosurgery, but the one that you don't need neurosurgery for is when it's in the sheath only in the orbit. That one we treat with observation, or if you need treatment because they're getting worse, radiation therapy.